Good evening, everyone. I'm Jennifer Kem, and we have our second or our third. This is our third speaker. I'm sorry. And it's about our topic tonight is sleep. And we have a wonderful speaker with us here tonight. Daniel Hall, PhD, is a licensed clinical psychologist at Massachusetts General Hospital and an assistant professor at Harvard Medical School. Dr. Hall is the co-director of behavioral sleep medicine and the associate director of utilization and evaluation research in the Health Promotion and Resiliency Intervention Research Center. Funded continuously since 2015, his research focuses on insomnia, fear of recurrence, and resiliency among adults affected by cancer and other health conditions. Dr. Hall has co-authored over 70 articles and chapters, edited one book, and has a virtual private practice in Massachusetts. So, welcome, Dr. Hall. I'm going to unpin myself and then you can start sharing.
Thank you so much for the introduction, and thank you all for joining this evening. I just want to give an extra congratulations to Marcia or Marcia. Congrats on that recognition. So that's and to everybody, it's really impressive the amount of physical activity you're all doing. So definitely keep it up. I appreciate your time and I appreciate the introduction. I would love to jump in. I'm happy to share my slides. I did bring some slides tonight because I find it's it's hard to capture our attention and sustain it for a really long time. And so I'm going to try to take breaks. None of what I say tonight is meant to be um, teaching you something that you're going to have memorized. I'd like to be a resource, whether it's the slides or if I can share with you, and I will, some tips of where you can go for help or more questions. I'm hoping that tonight you can learn a little bit more about insomnia and cancer and what you can do about it if you're struggling with sleep. So I'm happy to share my slides now. All right. Let me know.
Yeah, it looks good.
That's okay. All right. Let me see if I can make this a little bit bigger. Okay. All righty. So I just want to share, this is a little bit of my disclosure. I was speaking with Jen right before signing on that I do have two little ones at home. And, you know, I was going to say part of my disclosure is that my sleep isn't the best, but, also we'll talk about that in just a minute. For those of us, what's the difference between our sleep not being great and something like insomnia? But also for each of you, and then also I wanted to list, I provide some consultation to an integrative medicine company called Good Path, and I do have a private practice. But my the reason why I put this picture up is less of a disclosure and really more to get us started to think about what does a good night's rest look like to you. And for me, right now, it's easier for me to answer that question by thinking of what my kids look like, but that's okay. Just for now, whether it's for yourself or for someone else, just see if you can think of like when was the last time that you felt like you had a good rest? Okay. And I won't ask anybody to share that on the spot. For some of you, it was last night. For some of you, it may have been a lot longer ago. And I just do think it's important that each of us can think of what does it mean to have good rest? And for some of you, it has to do with a certain number of hours. Maybe for some of you, it has to do with how often you're waking up at night. For others, it may be about, struggling to fall asleep or even to wake up in the morning, get up out of bed. And so there's a lot about sleep that can be quantified. And I'll share with you here are some learning objectives. And, I'll share with you a little bit more about insomnia and cancer and how they're really common and overlap. But most importantly, what you can do about it. Um, this isn't sort of a scientific lecture on what is sleep and all the stages of sleep. This is going to be very focused on trying to empower you to make changes that you feel comfortable with if your sleep isn't the best right now. Um, and so this is the roadmap. This is the T in Boston. This is near where I live. Uh, but uh, we'll see. Hopefully, we're not going all over the place here, actually. All right. Um, I wanted to share just a few slides, a little bit about me and some of the background and work that I've been doing for the last few years, so that when I start to talk more about the nuts and bolts of sleep, you can also have some appreciation for um, the types of patients that I've seen, but also there's a lot that we still have yet to learn, and a lot more that we're still trying to study and understand about sleep. Um, I wanted to share right now. I work at Mass General Hospital, which is a large hospital in the Northeast, and and we have a few resources in our hospital for where patients can get treatment if they are having insomnia. Now, I realize I haven't defined insomnia yet for you, but just to share with you, if people aren't interested in medications, we do have a few services. But for the most part, um, there hasn't been really a lot of standardized consistency in the way people deliver insomnia treatment in our hospital. We have worked on some handbooks and chapters, but have never really developed a program yet. And so a big chunk of the work that I'm focused on is doing just that, is creating, and we've done this, sort of developed a 4 session virtual program that we call the Survivorship Sleep Program. And this is a type of therapy meant to address insomnia. And I realize I still haven't told you yet what insomnia is, and I promise we'll go there. Um, but what we do is we work with cancer survivors, anybody from diagnosis onward who's in treatment, post treatment, or living with advanced or metastatic cancer. And depending on the research trial that people are randomized into or enrolled for or eligible for, they may be enrolled in group visits or individual visits. And so we've had a chance to understand a little bit more how to deliver this. And we also have some research trials where we're understanding whether booster sessions help and how that comes up, especially around annual or more frequent cancer testing and surveillance testing. Um, But a lot of the work that we do is not only with psychologists who are delivering the program, but also a lot of clinicians in our hospital. We're trying to work more and more with APPs, advanced practice providers, um, as well. And this is kind of the boring slide. I just want to share this is not I, me, my Daniel Hall, who is this person. We're really supported by a huge team. We've been funded by the American Cancer Society to study sleep and cancer and interventions that work best. We're trying, also, we have a grant from the National Cancer Institute to try to understand what makes group delivery more optimal when you're working with cancer survivors doing this sleep intervention. And we're working with a variety of community partners based throughout Massachusetts because for these trials, we're recruiting just within Massachusetts. But I'm really definitely hoping with where we're going, we'll be recruiting nationally in the future. Um, but we work with a number of investigators, some of whom are oncologists, and also do a lot of research in cancer survivorship and quality of life. Um, I might skip past this slide. This is a little bit more of under the hood of what training looks like, but we have a lot of materials that we've been developing and standardizing so that people can be trained on this work in our hospital. And so far we're really reaching a variety of providers. These are people who have gone through our survivorship sleep program and are now delivering it independently, either in the hospital or at some other regional hospitals. So, what I'm going to tell you about is one of a variety of ways that we're approaching how to address insomnia kind of within our hospital. And now that I'm letting you a little bit know about what's going on and the workshops and trainings that we're doing, I want to now back up and tell you, okay, this is to slow down a little bit more and explain what is insomnia and why it's so prevalent, not just in our hospital and a big area of focus now, but why it's garnering so much attention across the world, certainly in the United States. And so happy, that it's being spotlighted tonight. So, insomnia happens when we're having difficulty falling asleep, staying asleep, or waking up, and it becomes chronic. So we can have something called acute insomnia, but I'm not going to spend too much time tonight talking about that because acute insomnia is pretty common and it's pretty transient. And what I mean is, a lot of us, if we're experiencing some difficulty or life event, we're going to have some disrupted sleep. And it's not to say that it's not important, but it's different than when it's chronic. And we consider sleep problems to be chronic when they occur 3 or more nights a week for at least 3 months. Now, if you're thinking to yourself, yeah, that describes me. Um, we'll get there also on the next slide a little bit more about the prevalence after cancer diagnosis and through treatment. But in general, this is pretty common. Okay. Insomnia is one of the most common mental and physical health disorders that there is, especially in the United States. And there's a lot that's sort of normalized about, like we'll put off sleep later, work hard, play hard, not sleep hard. you know, um, it's just there's sort of an uphill battle that we're working. So, but this is a very high prevalence. Okay, just in general, and this has nothing to do with cancer. That 10.8%, okay, 1 in 10 adults has chronic insomnia, untreated chronic insomnia. So it's a very big issue, and um, and we know there are a variety of things that reasons for this. Okay. And I'll also talk about that on the next slide. We used to focus a lot on whether insomnia was primary or secondary. So, like for instance, did your insomnia occur before or after your cancer came into the picture? And for some of you, you'd say, yeah, actually I had these problems sort of before cancer came into the picture, and then it certainly hasn't gotten easier afterwards. Um, And so we take all comers when it comes to CBT or when it comes to treating insomnia. We don't really differentiate between primary and secondary anymore. We used to sort of consider that, but now when it comes to a diagnosis, it's just insomnia disorder. Okay. Um, so as we get older, there's a higher risk that we're going to be experiencing insomnia. There's a higher incidence rate. So even if you've never had insomnia before, as you get older, you're more likely to even experience your first sort of period of insomnia. And there are a variety of reasons for that, but we won't go into that too much tonight. It's just good to know. And um, all the more important for us to have routine screening really for insomnia. Um, we know that there are a number of reasons why women experience insomnia at higher rates. There's some comorbid psychiatric illnesses that tend to be more prevalent in women, including depression. And depression and insomnia are very highly linked. Very, very, very highly linked. In fact, treating one, treating insomnia addresses depression better than most depression treatments available. It's very, very highly correlated. But also in terms of both gender and sex, there are a number of both social and physiological changes and reasons why women can experience chronic insomnia at higher rates. And that can change over time as we age. So, presence of psychological and medical conditions. I'm just going to jump down to cancer here. This is one obviously core topic that brings us all together tonight. Um, and the reason, I think why we've had a lot of success from grant funders to focus on insomnia is because it's so prevalent. Um, this is just a slide showing an increase in prevalence. You probably are familiar with this. In general, in the United States, cancer survivorship is increasing. And that's really the takeaway of this slide. And that's a huge success story in many ways. In other words, the number of adults who are living after a diagnosis of cancer is just increasing. One of those reasons is because, in general, as a population, we're getting older. Our mean age is just shifting. But also, advances in treatment and early detection. But it does mean more and more cancer survivors are living with late effects of treatments. And those can often, including and also fear and worry. And that can perpetuate a lot of insomnia. So, this slide, I think, summarizes quite a lot of research and isn't isn't at all an overstatement. In fact, for everything that you see listed on here, there are meta-analyses that have studied the relationships between insomnia and mental health, immune functioning, daily functioning, physical health. And so sleep isn't just sleep, it affects our daytime functioning. And for cancer survivors, it affects a variety of really important quality of life outcomes. One of the areas we're also focusing on in our studies is work absenteeism and presenteeism. In other words, we know cancer survivors with insomnia not only are having more difficulty attending work if they're working or working the same number of hours, but also while they're working, their challenges sometimes perceive, some cognitive functioning challenges, sometimes fatigue, sometimes um, really just what we call presenteeism. And so we're just understanding more and more really insomnia isn't just sleep. And I think that's just a really important take home message. And, it's not to, this isn't about ascribing blame because we can modify insomnia. That's sort of the wonderful success story that we've seen in a lot of cancer survivorship lifestyle medicine is we can move the needle on some really important health behaviors. And we've seen insomnia is a huge success story when it comes to that. Um, Before I share with you a little bit more about the research on how to treat insomnia and some of the skills that you maybe even could start using tonight, I just want to tell you about how we screen for insomnia or what the guidelines at least say we should be doing. Okay. There are guidelines that are written by the National Comprehensive Cancer Network, and these are survivorship guidelines that are meant to be followed ideally in a best case scenario by our oncology clinicians and the centers that if they're operating in a center. And ideally, what these guidelines say is that at every clinical encounter with cancer survivors, we should be assessing their sleep. Now, right, easier said than done. I understand. There are lots of challenges and feasibility to asking every question at every visit. But I just want you to think for yourself, um, sort of, well, let's walk through, actually, let's walk through these three questions, okay, together. And I had a chance to, I didn't write these guidelines by any means, but I had a chance to write a commentary. And so that's sort of what I pulled up here. Commentary advocating for oncologists to do this a little bit more routinely. Okay, so let's look at this first question. These are three yes no questions. And they're meant to be like easy to answer because they're supposed to be for patients, not like nerdy scientists. Okay. So first one, are you having problems falling asleep, staying asleep, or waking up too early? Now, you can put this in the chat if you'd like, but what do you think this is assessing? Maybe insomnia? Yeah, you're exactly right. If you thought, this might be assessing insomnia, that's exactly right. These are, and we'll get into a little bit more why there may be problems falling asleep, staying asleep, or waking up too early, but that's right. These other two questions assess other sleep-related concerns that do often come up in cancer, but they involve a separate kind of treatment. So number two says, are you experiencing excessive sleepiness? Any guesses what this might be referring to? Excessive sleepiness.
Like
So this one,
sleeping like during the day.
yeah, yeah. And so this could be like narcolepsy. Okay. Again, if you um, have narcolepsy and it's not being screened for or treated, it's a big issue. And this question is um, one of the screening items that we use for addressing that. Okay, number three is about snoring. Have you ever been told that you snore frequently or that you stop breathing during sleep? All right, I'll look in the chat. Any guesses what this one is referring to? Yeah,
That's
apnea. Yeah. I'm sorry. I think I saw that already. That's right. So this one's sleep apnea. Yep. That's right. Two or three. Number two could also refer to sleep apnea as well. That's right. Um, Number two and three hint at something that may be what we call an organic sleep disorder. And those are often treated with medications or by your colleagues in sleep medicine. And there may be, or there can be some other types of hybrid treatments. But this very first one, it turns out we're not really supposed to be our gold standard treatment may surprise you, medication. Okay, so if for anybody who's answering yes to this, what the guidelines say is that you should be then referring for what I'm going to show you on the next slide, something called cognitive behavioral therapy for insomnia. Okay, it doesn't say if you're experiencing this, the first thing that you should try is trazodone. Even though many people who we work with are well intentioned and they may even prescribe that for their patients, and it may even work, it turns out it doesn't work as well as this other treatment, which I'm going to tell you about. And it also doesn't tend to have, well, anyway, um, I'll just mention this table down below was a survey done at some very well resourced cancer centers, some National Comprehensive Cancer Centers, NCI designated, very supposed to be like the top of the top. And even in these well resourced institutions, patients were, um, only sometimes, you know, most like sometimes or so, being asked, but very often people were never asked. And so I just, encourage it's okay to ask. It's okay to bring this up also with your doctors or nurses or whomever you're following up with for many of you may even be following up with your PCPs. And you can let them know, I'm struggling with sleep and interested in a referral. Okay. So I hope by now um, you have some understanding of insomnia, that insomnia, it's not the short-term thing, it's acute, or I'm sorry, it's chronic. It happens 3 or more nights a week for at least 3 months. And we know that insomnia seems to be um, treated with something, but we haven't even really talked about what that is yet. So here's what it is. It's kind of a mouthful to say CBTI, or cognitive behavioral therapy for insomnia. And this is a really important treatment because it's been endorsed by the National Comprehensive Cancer Network. So they've reviewed all the evidence and they say this should be the gold standard if it's, we should be referring patients to receiving this type of treatment. But also, in the in non-cancer populations in the general public, um, you know, uh, it's also been endorsed by the American College of Physicians. Also, every sleep society there is has endorsed it, but that's not as, I think, powerful as hearing, these large bodies endorse this treatment. So what it entails is typically an intake with a therapist or clinician where they're going to ask some questions about your sleep. And I'll share with you on the next slide the types of questions that they'll ask. Um, I'll just do a quick sneak peek. There are a few factors over here, and then, okay, so we'll come right back to this, but they're going to ask you some questions that will inform where you really focus your time and energy during the 4 to 10 sessions. Okay. Now, where does this number 4 to 10 sessions come from? Well, it's a very skills focused program. We don't talk a lot about the past, and we really don't talk a lot about the future. It's very grounded on what's your sleep like last night and comparing that to the night before and making predictions for the following night. And so we gather a lot of information from you over those 4 sessions as you're learning and applying 5 different skills. Okay. Depending on the program, depending on the protocol or treatment or the therapist, you may not use all 5 of these skills, but 100%, if you're ever learning CBTI, you'd be learning some combination of these 5 skills. And in the best case scenario, you're learning all 5 of them. Okay. I'm going to go through and explain what each one is because it's very what I call psychobabble, you know, you know, words that anyway, it sound like you sort of know what it means, but it's could mean anything. So I'll go through each one and explain the concept and maybe a tip or strategy you could start using tonight. Okay. Um, Even though it's a combination treatment, we know that you don't need this indefinitely. We know that most of it's been studied a lot over the last few decades. And most of those research studies have tested, again, programs that are between 4 to 10 sessions. So there's no magic number. I've worked with some people and they find after 3 sessions, they've learned what they really need to. And some people really feel like they benefit from additional boosters over the months and years. So, but these are typically 30 to 60 minutes. And, you can do this face to face, virtually, either way. It's been tested across the board, and we know it works well both ways. It's efficacious both ways. Um, for those of you who are data nerds and more into the science, um, if you've ever looked at a meta-analysis before, they'll have something called an effect size, and and it's a way that we just judge the body of literature on a given area. The effect size for CBTI, another how well does it work versus a placebo control or an attention control. Um, these are larger than effects for cognitive behavioral therapy for anything, CBT for depression, for anxiety. So I think of insomnia as like the big success story for CBT. And a lot of people have heard of CBT or cognitive behavioral therapy before, but not everybody has heard that there's a type of CBT that's very specific to insomnia. Um, I will say the CBTI program and protocol um, can look very different from having cognitive behavioral therapy for anxiety or depression. But these tend to be very, very large effects. So, you know, it's a great program, and I think that's why, we tend to have a lot of enthusiasm for it. However, there is sort of a downside, one caveat, which is basically that it's not a medication, is pretty much what it comes down to. Medications have their own list of pros and cons, but certainly one of their pros is that it can be a lot more feasible to take a pill for many people, not everyone, than to attend or implement behavior change, attend sessions. And you know what I mean? It really takes a certain level of commitment and willingness, really, to change some of your behaviors and expectations about the bed. But the good news is, if you're willing, um, then CBTI can still um, really work, even with people where we've worked with people who are shift workers, who are on a variety of medications, and these skills can still be very, very helpful. So, all right, let me explain to you a little bit of what we try to treat, because all of the skills really try to treat sort of the same core issues. And then I'll tell you what each of the skills involved. Okay. I think I'm doing okay on time. Um, all right. So this model is not meant to be um, something that so this is something I'd like to walk through this together, because I really like this figure. And for me, it is one of the easiest ways to explain really what those five skills are and what we try to do. So this graph represents somebody with insomnia. Okay. Now, if you're on the call and you're thinking, you know what, I have insomnia, you might think of yourself in this example, but also you can just appreciate this might be someone else, somebody who has insomnia. And what we do is we start on the left of the graph of the figure, and we work our way almost like over time over to the right hand side. Okay. And so what we do is we start on the left here, and this pre-morbid insomnia, this is another way to say this person doesn't have insomnia yet. Okay. None of us were born with insomnia. Now, some of us had some risk factors, maybe some of our genes, and there can be some genetic risk. Some people are sort of poor sleepers or light sleepers. Um, Another predisposing factor can be a history of childhood trauma. Okay. Doesn't mean you're going to have insomnia as an adult, but we know for sure having a history of childhood trauma can be a risk factor. There are a variety of risk factors. In fact, we even talked about some earlier, like age. For some of you who lived maybe most of your life without insomnia, but only recently it's an issue in the context of cancer. Just understanding age may have been a predisposing factor, but all along, all of these predisposing factors don't mean anything unless something comes along and triggers that very first event of insomnia. Now, I don't know what it was for those of you on the call who are experiencing insomnia. It may have been related to cancer, maybe not. Sometimes this is something like a work transition or a breakup or taxes. I mean, it could be whatever it was, but something that kick-started that first period of time where you're having 3 nights or more in that week, of having poor sleep, and that really built up to 3 months. Now, what we know is that's important, but you could spend your whole time in therapy focusing on what it was that happened that got it started in the first place. And what we know is you probably won't treat your insomnia by doing that. On this graph, this represents our severity of this person's severity of insomnia. And even though, as you can see in blue, whatever happened that kickstarted insomnia, it certainly set them over the threshold. No doubt about it. That event, whatever it was, um, it's it came and it went. Now there are some things like cancer, for instance, that aren't a one-time deal. But the experience of an initial diagnosis or experiencing certain late effects like hot flashes or early onset menopause or headaches or nausea or fatigue, any of these things. I mean, there could be lots of things that actually perpetuate the insomnia. And that's what we can focus on in yellow. But what I'm really focusing on is what got it started in the first place. And it usually is some some stressful event. However, one of the uh, I think one of the most elegant things that we've learned about insomnia is that you don't have to treat everything that's driving it. You just have to treat certain things. And those things in this graph are represented in orange and red. And if you really just focus on those things, you'll be okay because you can never predict the next precipitating event, always. But you can get skills to manage those events if they come in up and for making sure you're not developing these things in orange or red. So, what are these things in orange and red? They're the things that keep insomnia going in the early stage and in the chronic stage. And that's what we focus on for treatment and get you back down under acute treatment and with full response. And so, these things have to do with our expectations of the bed and bedroom and these psychological factors and principles of conditioning. And it might sound a little silly and unusual, but what we've learned over time is that the bed is not a place for sleep, but it's a place for being awake, for struggling, for being worried, for solving problems, for being a failure. We also learn um, that some of the skills and techniques that work really, really well for us in our day-to-day life, like related to managing work or managing our home or managing other things with to-dos and solving problems, those same sets of skills will keep you awake at night instead of helping you relax and get your body less aroused and more calm and relaxed. Um, I'm gonna jump right in. It. I think it's actually. If I jump right into stimulus control, this is one of the best ways to help introduce this concept of conditioning and why we focus on what's going on when your body is actually touching the bed at night. So many of us, as we start developing insomnia, we start doing a variety of things when we're awake. Um, and we try to stay in bed as long as we can. This is it's well intentioned and on the surface it makes a lot of sense. Like how are you possibly going to get more sleep if you're up out of bed? But what happens over time is we start doing more and more things in bed that aren't sleep. And it's just because in our mind we're either winding down for bed or if we're going to do it anyway, let's do it while we're in bed because then there's a chance I might just fall asleep doing it. It's a completely understandable and logical idea, It turns out to work completely against us when it comes to sleep. And here's why. Um, Raise your hand if you remember hearing or learning about, maybe in high school or earlier, about Pavlov or Pavlov's dog. Okay, some people are like, I don't know what you're talking about, Daniel. That's okay. But Pavlov learned that this dog would salivate when it heard a bell. Okay. And it learned to associate that bell with food. And we've learned in many, many ways all throughout our lives, we operate like this constantly for things all around us in life. And it's good, it's automatic. We do things right away and we don't even have to think about them. We stop at a stop sign or a red light and we assume when it's green, we'll go. We make all these assumptions about our safety in the world around us almost automatically all the time. One thing that we've learned is when people develop insomnia, very quickly, their brain learns to be confused. The bed isn't a place for sleep anymore. It's a place where it's fair game for something else to happen. It could be eating, could be reading, maybe watching TV. For many of us, could be social media or working or texting. Um, Again, there's no saying like you're bad and wrong for doing this, but paradoxically, it's training your brain to expect to be awake when your body's in bed. Instead, what we want to do is train the brain to expect nothing that's stimulating at all and only sleep. And what can happen over time, it's amazing. And it happens pretty quickly. Our brains, when we look at the bed, will just start feeling sleepy. And when we're actually physically in the bed, it's much easier for us to stay asleep. The brain isn't preparing, in other words, for the next fight or flight response. Um, by the way, we keep sexual activity and intimacy in here because for many people, the bed might be a place where that might be one of the only places that they're experiencing activity or intimacy. We don't want to take that away from anyone. It's a wonderful thing. However, if you're able to do that outside of bed, your stimulus control will be even better. Okay. If the bed can only be a place for sleep. Um, I'll give you examples where this comes up all the time. It's where people are reading in bed, doing a podcast in bed. Um, Another example is in the morning, waking up and wanting to have coffee in bed with a partner or a loved one and having that be a routine. It's well meaning, but well intentioned, but it trains the brain to be awake and it's very confusing. So we cut that behavior out. Um, okay. Just for the sake of time, I'm going to move through the next few ones a little bit more quickly because I want to leave some time if there are questions. Okay. Sleep restriction sounds pretty scary and it is a misnomer, okay? Because you're not restricting your sleep. We're just restricting your time in bed. And the reason for this skill and technique is that for many people with insomnia, their sleep is not continuous, it's not all at once. And that's a problem because you don't get a chance to cycle into those later stages of sleep, like stage three, four, and REM, that are so healthy and restorative for us. And so what we do is we take the total amount of time that you're currently sleeping and we say, okay, that's probably all the time in bed that you actually need. You don't need more than that. And you might say, oh, what? You are having me stay up until 2 a.m. and get up at 7? That sounds like the opposite of what I'm trying to achieve. I'm trying to stay asleep, not be up until 2 a.m. What are you doing? This is so silly. The reason is our bodies don't work according to logic, okay? It works according to patterns. And our bodies are very responsive to being given a set amount of time when you're allowed to sleep. And very quickly, your body starts getting continuous sleep right away. By the way, we have ways to quantify all of this. We use sleep diaries where you track, when you're waking up in the morning, et cetera, times out of bed. And we make sure that people don't have contraindications. And there are a few for sleep restriction, which is why I don't want anyone to do this using an app. I know there are apps out there that will do this, but I think that could be dangerous. So for some of you, very few, but some of you who have a history of bipolar or mania, you wouldn't do this particular skill. If you have a history of seizures or epilepsy, you wouldn't do this particular skill. Okay. Also, if you've recently had some active thoughts of suicide, it's just not the skill that we're going to focus on. Okay. It turns out sleep restriction triggers all of those things that I just mentioned. And so it's most important that we have other skills to tailor this one if that applies for anybody. Okay. But it's just really important. This is done according um, to a very tailored schedule. But our bodies very quickly develop efficient sleep, sleeping efficiently all throughout the night. 85% or more of our time in bed is spent asleep. And if we give it another 15 or 30 minutes in bed, our body will respond by graciously sleeping for another 25 to 30 out of those 30 minutes. It's really wonderful. So establishing that percentage is really, really important. Okay. I'm going to move past sleep hygiene because I've been told this is some information you've learned before, maybe through this program. But if you haven't, the other place where you can find sleep hygiene is basically anywhere on the internet. This is the most widely available skill there is out of all the CBTI skills. Um, and um, it's okay. It's not bad in terms of skills, but I just want to be straightforward about it. Of all of the 5 skills that have been tested with CBTI, the 5 techniques, skill number 3, sleep hygiene, is the least powerful one. And in fact, with some research studies, it's no better than control arms. It's not to say that it's not helpful, but alone, it doesn't cure insomnia. It's not as effective. And so oftentimes people come to me or other people and they say, look, I've tried all these things. And I'd say that's a great start, but it was probably frustrating to being told like a million things to do and get it wrong. So, or it's not enough. I do think it's helpful to have something you can control. And everything on this list, for the most part, it may not be easy to control, but you could control it. And I think that's always important. So no harm for this one, but if you want to spend a lot of time on any one skill, it maybe doesn't need to be this one if you're struggling with insomnia. Okay, relaxation training. Um, there's been a lot of research on relaxation training, and it is great. It is evidence based. It works better than placebo and attention controls. And it works really well 2 times, 2 different ways. One is right before bed, or I'm sorry, 3 times. Right before bed, in the middle of the night if you're awake and trying to get back to sleep. But the third one is sort of counterintuitive. I recommend you do relaxation sometime during the day. Many of us carry a lot of stress into the evening. And if we wait until then to practice relaxation, we're setting ourselves up for a lot of work. And so I would just recommend, try a little relaxation during the day and trust that Dr. Hall said it might improve your sleep. Certainly doing this right before bed and in the middle of the night absolutely is evidence-based for getting back to sleep more quickly. And there are many important reasons for this, but it quiets the body and it quiets the mind. And that's really the most important goal there is when it comes to getting back to sleep, not solving problems of worries about recurrence, for instance. So relaxation can be really powerful tool I'd encourage. And then skill number five is really where I spend a lot of my time as a psychologist. But depending on the therapist or who you're working with, they can spend different amount of time here. This is where we address thoughts and the way that your thoughts and expectations don't help you. They actually hurt you when it comes to your sleep. Sometimes we develop these beliefs like I need a full glass of water before bed. I don't know where, but and that one's easy to address. Other things like I have examples on here about fearing recurrence, very common in the middle of the night with patients who I work with. And we work to develop a list of relaxing responses or reframe thoughts. And they'll have them written out by their bed and they can focus on those thoughts if they're worried about recurrence. And then in our program, we teach something called worry time. And this is something for worrying, actually. We give people go ahead permission to worry. We're not going to tell you don't worry. You've been told your whole life don't worry. We'll be the first program to tell you don't worry. I mean, go ahead and worry. I'm sorry, go ahead and worry. However, just don't worry at night. Pick a time during the day that you can protect, whether it's walking the dog, watering the plant, making the coffee, not when you're spending time with your kids or grandkids, not when you're, you know, focused on your significant other, not when you're in prayer. Like, think of when you can use 10 minutes. And for those of you who say, I can't think of a single 10-minute time, maybe using the restroom, maybe taking a shower. Think about these times when you can worry about recurrence. And I do think this is nice to, have a therapist who's available just in case you're feeling like, okay, what do I do after that? But bottling it up isn't the answer, but waiting to think about it at night isn't the answer either. And just saying, I'll think about it later also isn't satisfying. When it's a big fear and a big worry, do yourself a favor and the courtesy of being honest and picking a time when you know you'll think about it, not just I'll put it off and think about it whenever tomorrow. Give yourself that worry time. And what we've learned is it helps people actually sleep better at night. So I'm going to move past this. I'd mentioned, yes, I do a lot of clinical work, but a lot of the work we're doing is research. We're studying not only how sleep affects, CBTI affects sleep, but also things like pleasure, reward, rumination. We're also trying to be a lot more inclusive in the work that we do. So I'll just sort of leave it at that. Where this is also, again, an emerging, we're seeing CBTIs being used for hoarding disorder, all sorts of things. It's phenomenally interesting to me that you focus on these very concrete behaviors, what I just explained to you, and you can help treat someone with depression too. It's pretty amazing. Okay, this is my last slide. This is just often people ask, what are some apps out there? I'm not affiliated with any of these apps, and I've used some and not others. I would just say there's research done on whether apps work for addressing insomnia, and they can actually. They tend to have smaller effects than the when it's delivered with a therapist, but it's not a bad option. But I do think for many cancer survivors, working with the CBTI therapist is really the ideal. So I will stop there. I realize there may be a question or two, and